Center Hour. This is a program of the Center for Biomedical Ethics and Humanities. We bring you these programs 20 times a year on a weekly basis during each semester. We're very happy to see all of you here today, and we think you're in for a very interesting, stimulating program. The Medical Center Hour today is a program entitled Good Intentions. This phrase is followed by an ellipsis, ... to indicate that there's more to it than just good-heartedness. This session is the School of Medicine's Richardson Memorial Lecture, a yearly presentation with its own history of good intentions and good follow-through. Indeed, this annual lecture occurs to remind and encourage our health professional students, house staff, and seasoned practitioners to be reflective about their work, and also about the errors that regrettably do occur in the course of practice, and especially to attend with care and compassion to the persons who are their patients. Made possible by the family of the late Jessie Stewart Richardson, this lectureship has its origins in Mrs. Richardson's untimely death, a result of tragic inattention and adverse incidents during her hospital care. Remembering Mrs. Richardson's long career as a school teacher, her family invested funds from her estate in health professional education, especially around medical error, patient safety, and caring for patients as persons. The Richardson family is represented here today, as every year, by her son, UVA medical alumnus and local retired physician, Dr. Don Richardson, who's seated in row 2 right here. Welcome. The Richardsons are thus helping the medical school and the medical center to emphasize health professionals' commitment to care that has the patient at its heart, and to explore without fear the medical mistakes that do happen and our individual and institutional ways of responding to and remedying harmful errors in practice. Over the last 12 or so years, Richardson Lectures have brought many distinguished speakers to Charlottesville: physicians, physician ethicists, physician writers, a poet, patients' family members, and leading experts on medical error. This year, we've looked no further than home for our subject and our speakers. Good Intentions is a program about UVA. A UVA patient, indeed a UVA faculty member, a UVA family, a spouse also on the university faculty, UVA clinicians, UVA hospitalizations. The presentation is a rich mix of all the good intentions behind Richardson Lectures: medical mistakes, paying attention to the patient as a person, the patient and his family as the physician's best teachers. In the complex, sophisticated world of the tertiary care hospital, despite good intentions, advanced technology, expert staff, and a 24/7 capacity to handle life-threatening problems, things can go badly awry. What happens when a patient who is expected to die of one illness suddenly dies of another? What if his doctors were vigilant in his care, but vigilant while facing the wrong direction? Does this constitute medical error? And what of attention to the patient as a person, and to the family, bereft, disappointed, aggrieved, mistrustful? After this particular patient's last illness and death, his family and friends bravely challenged the clinicians and the hospital to learn something from what had happened. Our speakers are here today to share with us some of those painful insights and heartfelt lessons. We welcome, on my immediate right, Dr. Daniel Becker, general internist and the Tussie and John Kluge Professor of Palliative Medicine. Dr. Becker also directs our Center for Biomedical Ethics and Humanities. He speaks today in his capacity as the patient's longtime primary care physician. We also welcome, on my far right, Professor Jenny Strauss Clay, the William R. Keenan Jr. Professor of Classics at the university. Professor Clay is here, however, not in her capacity as an expert on ancient Greek literature, but rather in her role as spouse, a role that in these last 2 years has acquainted her intimately with the sort of tragedy the Greeks brought to the stage more than 2 millennia ago. 3 quick mentions. We thank the Medical Center's Committee on Patient Safety for being our partner in the Richardson Memorial Lecture. In your handout, also please find a message from Dr. Don Richardson. For the dozen or so years of these lectures, he has graciously let our lecturers do all the speaking to you. Today, he sends a brief written note to encourage all of us in the cause that he founded in his mother's memory. Also, on your way in or out of the auditorium, you may have noticed a bowl full of these little red foil-wrapped hearts with little pieces of paper attached to them. This is a service project of the medical school's chapter of the Gold Humanism Honor Society. These hearts are for you, sweet reminders of why we do the work that we do, that it's not just about us, but about our patients, that every patient is a story, and that the secret of the care of the patient is in caring for the patient. Help yourselves to these hearts and take a couple extra to pass along to your colleagues this afternoon. And now the Richardson Lecture, Good Intentions, with Danny Becker and Jenny Clay.
Thank you, Marcia, and thanks for the audience. So this is going to begin as a traditional case discussion, but then I'm trying to include all the points of view that arrived at a difficult outcome, difficult lessons, and as Marcia mentioned, it's all in the UVA family. Just my full disclosure, I've dropped the baton more often than I'd like to admit. So I'm not standing here as some kind of a paragon. I'm just like anyone who tries to do his or her best. So the patient, 78 years old, he had about a 6-month illness of, it turned out to be a urothelial cancer, which is a terrible cancer, treated with a diverting colostomy, palliative radiation therapy and chemo. He had recurrent upper tract urine infections, made him very sick. He was back and forth between urology, general surgery, radiation therapy, oncology, recurrent urosepsis. I probably was more involved in the telephone care, involved in sort of pointing him in the right direction. His final admission, he came in with chest pain. He was coming off of some radiation therapy and chemo. He was nauseous and dehydrated. Prior to the cancer, he had a history of coronary artery disease. He had bypass surgery. He also had a dilated thoracic aorta, but he was very stable from a cardiac perspective. He was admitted, acute myocardial infarction was ruled out. He continued to have nausea, anorexia, wasn't drinking or eating, and yet discharge planning was initiated. 50 hours into his hospitalization, and it was just a few hours after family and friends went home, he developed much worse chest pain, hypertension, he had a cardiac arrest, and he was unsuccessfully resuscitated. And the clinical opinion is that he dissected his thoracic aneurysm. So I'm thinking about this. I remember the movie Rashomon, which is a story about actually a crime, and what really happened is based on points of view. Turns out that the Rashomon effect is in the biomedical ethics literature, article co-authored by Ann Mills, who's at UVA and in our center. So the patient, let's start with the patient, Roger Stein, who is a internationally known professor of English and art history. His spouse, Jenny Clay, assures me that he would appreciate being the subject of this talk or the grand rounds. And I'm sure that he went to see Rashomon in college just as I did. So I had to review this record from Epic in the early days of Epic, and hopefully you can't read any of that, but I call that the Epic kaleidoscope. It's much better now that we're using Epic in the hospital. So the surgeon's point of view, and remember there have been a couple of surgeons. At cystoscopy, no abnormalities were seen in the urethra. Then further in, there appeared to be extrinsic compression of the trigone from a mass external to the bladder. So the urologists were calling it rectal. Previously, the colorectal surgeons had suggested that it was a GU problem. He eventually went to open exploratory laparotomy, where it was determined that what was going on was started in the bladder and was invading posteriorly into the colorectal area, and it was unresectable. So I went to look at the pathology with the pathologist who turned out to know the patient. First of all, we reviewed the rectal biopsy, which preceded the exploratory laparotomy, and the rectal biopsy thought that maybe it could be coming a rare cancer from the stomach, a Linitis plastica. So we were sort of go outside the pelvic realm, but suspects that it represents metastases from the upper GI tract, or possibly a bladder ureteral urological problem. He was cystoscoped, and the bladder biopsy raised the question of a bladder primary with direct extension of metastases to the rectum. So again, there are some different points of view, even when the pathology was reviewed. I think I can go through this fairly quickly. You can recognize that as you get into this area, the cells start to look more malignant with large nuclei and scant cytoplasm. This is a biopsy from the bladder. This shows the cancer invading the bladder wall. It's very interesting to me to look at the material with the pathologist, something that I rarely do these days, but it's really part of classical training in internal medicine to always review the pathology and just to see the look on the pathologist's face, because something like this really looks awful, and you don't really need to spend much time looking at to recognize that it's awful. So back to the hospital. The last hours, I think it was a Friday night, and so we're talking about the cross-cover resident's point of view. So this is a resident who got a sign out, and we're working on the sign outs. This is a problematic area of patient care. Remember the relay race, we're handing people off, not batons, but that's where mistakes occur. So the resident didn't know Roger very well. Actually, the UVA hospital at night does not look like this, but I don't think it's ever that empty. Even the new expansion is already populated. So, but the idea that it would be a nurse who doesn't know the family, doesn't know the patient very well, and working without a lot of the support systems that the day shift has. The kind of medicine we practice has been called Lesion-Centered Medicine. This is a book by Michel Foucault. The idea that in the 19th century, doctors were able to compare clinical findings to pathological findings, autopsy findings, and recognize that the clinical findings were related to lesions. Of course, in primary care, a lot of the things I see don't have lesions. And pure science isn't the whole story. This is a slide from Jack Coulihan from Stony Brook, a survey. How much of good doctoring do you consider to be art rather than science? And about 50% of everybody thought that art had a lot to do with good medical practice. Well, after the patient died, the family spoke to the patient representative. And all hospitals are required to have patient representatives. This is a mandate from the Joint Commission and CMS. UVA has 3 full-time patient reps. If the discussion through the patient reps aren't productive, then that discussion can go up to the state or even nationally. There are about 150 grievances, complaints and grievances a month. So what do people complain about? Delayed care, poor care, equipment failure, financial constraints, organizational change, for example, construction, for example, Epic, and then problems related to patient or family or caregiver delayed discharge, the delayed discharge. So this is a slide I made from an article by Croxberry that attempted to catalog all the kinds of medical error. So thinking is dangerous. Probably, if you had to point to a medical error in this situation, it had to do with the framing effect, the fact that he got admitted to cardiology. The acute cardiology service rules out acute myocardial infarction. And nobody was really thinking of the aneurysm, and they certainly weren't thinking or paying really close day-to-day personal attention to the fact that he felt awful, and the family knew he felt awful, knew he looked awful. So we developed tunnel vision, and that's something that I hope we can talk about in the question and answers. I should mention that throughout Roger's Odyssey, the one person that seemed to provide reassurance to the family and the patient, who always seemed to be there, caring and coordinating care, was a nurse practitioner, Meg Barkley, who works with colorectal surgeons. So this is a team-based practice, and we need a lot of it. Well, cognitive error is not new. Hippocrates warned us that judgment is often difficult. You can always find a quote from William Ostler, who is really the godfather of internal medicine. But no human being is constituted to know the truth, the whole truth, nothing but the truth. And even the best of men or women must be content with fragments, partial glimpses, never the full fruition. And he probably didn't see Rashomon. Often the personal point of view, I'm glad that there's some people from hospital administration here, because they hear a lot from people like me complaining about personalized care and what happens to personalized care when we talk about clinic throughput. But really, like it or not, we've got healthcare reform and all the questions it poses. Medicine is 16% of the GNP, and pretty soon we're only going to get paid if we do a good job. So this is the world we live in, and I think I certainly get that. But that there's some tension there. So sort of back to street level and how people felt, when we try to be a good doctor and we're talking to families who are really unsatisfied, disappointed, incredulous even. How could this have happened? So the Hippocratic Oath asks us to do no harm, but doesn't really ask us to do good. or be good, and that raises the question of virtue. And of course, people write about virtue. This is from a chapter by a bioethicist, William May. A whole list of virtue, and I put this slide up not to remind us that we have to be paragons of virtue, but to create an opportunity to talk about humility. So we're stuck here in Jordan Hall, and we learn virtue across the street in the Learning Studio in the Broadmoor building. But we learn humility at the bedside, and I found a quote from Ostler again that conveniently enough had to do with aneurysm of the aorta. There's no disease more conducive to clinical humility than aneurysm of the aorta. But I think most often, and more to the point, we learn humility when we take the time to listen to the family and hear what they're going through. So I invite Jenny Clay, who's a friend, colleague. I've known her as long as I've known Roger. So.
From Dr. Becker's slide, you see a man of 78 with terminal cancer, of a particularly aggressive kind, and with a previous history of heart disease. I see a man who nobody thought was 78, a man who, since his heart surgery over 15 years before, went to Martha Jefferson's cardiac rehab program 3 or 4 times a week, which became a kind of family for him. Most of the people from all walks of life had multiple health problems, diabetes, obesity, and so on. And right before he got sick, Roger volunteered to become a mentor and had even gotten his TB test and name badge, which he was very proud of, and was looking forward to encouraging others to stick with the program. Roger was also a pillar at the Jewish community, volunteered at the synagogue preschool, and only realized that he had tithed himself when he figured out his taxes. The summer before he became ill, we traveled, as we did so often. Some old favorites, some new places. Roger, whose field was American Studies and American Art, a field in which he was a pioneer, was working on a project which I got him into, involving the first American archaeological expedition. He wanted to go to the Greek island of Samothrace because his boys, as he called them, the 2 young American excavators, adventurers, who were really the first to undertake an American archaeological expedition, they had stopped there on their way to excavate in Assos, in Turkey. And so we went, and it was fun. But something was not quite right. Roger had to pee a lot. And of course we thought it was the old man's disease, or as one friend on our trip to Egypt once called it, the prostate parade. But after we returned, he went for a short trip to see his sons in Quebec, and on his return, getting an appointment to see a urologist, it has to be said, took about 3 weeks, and things were getting worse fast. And I do have to mention, her name has already been mentioned, and I think her halo and her little wings are sprouting, the name of Meg Barkley, who helped very much by staying on top of things and coordinating and explaining and supporting. It's all very complicated from the point of view of a patient, there's appointment here, there's appointment there, each one requires this will be there. You really need someone to guide you through the maze and the labyrinth. And I hope you can find more such wonderful people. And there were others along the way too, kind, supportive, funny. At the urologist, he was diagnosed with kidney failure. That was a bit of a shock. Enough tubes were inserted. A few days later, and we're talking November 13th, and the only reason it was so quick is that one of my colleagues is married to one of your pathologists. It usually takes a week of waiting. Diagnosis, cancer, and I didn't see his face, but I believe I knew it was happening. It wasn't clear what kind, and that was a rather complicated. Tests, more waiting. And meanwhile, Roger was increasingly in pain and uncomfortable. Infections from the kidney tubes entailed visits to the ER, which is not a happy place. Over the course of Roger's illness, we were often in the ER, and we all know about the overuse of the ER, especially by people who have no doctors, no primary care physicians, and no insurance. But it also is true that people who get sick after 5 p.m. apparently have no other place to go, and often no bed can be found. Finally, surgery was planned for January 5th. And remember, this has been going on since November 11th. That's a long time. Roger was admitted to the emergency room on January 2nd because of renal infection. These were recurring throughout. Surgery. Roger, wisely perhaps, did not want to know too much about what was going on and what they were going to do. But I'm a Greek scholar, and I Googled, and I know what exenteration means, and I have to say I was absolutely terrified. But surgeons are amazing people. They really exude confidence, and I guess they really have to in that business. Do they all wear beautiful suits and have fontans? Some do. We, and Roger's sons were there, we were told it would be a very complicated operation, maybe 10 hours before he got out. But the surgeon said the longer, the better. An hour later, we get a call. He's gone into surgery. And 40 minutes later, another call. Nothing to be done. A palliative ostomy to relieve the pressure. Otherwise inoperable. The surgeon arrives. He's clearly crestfallen. The braggadocio is gone, with defeat of sorts. We could tell. And I imagine you in your careers have had to cope or will cope with many such events. And he tells us, well, 6 months at best. It turned out he only had 2. When Roger was first diagnosed, he told me, I've lived a good life, and I'm not afraid to die. When he came back to the room, he knew something had gone wrong, because he was out so quickly. He asked his son about the prognosis, and Jonathan tells him. Roger was clearly shocked. He's quiet. He thought he had a year or 2, and we were finally going to get married on March 27th. We had planned a trip to Prague. And then, quietly, taking it all in, he nods his head. And then they talk about radiation, chemo, palliative care. So we go home with neph tubes and an ostomy. And only once did Roger actually break down and cry. And it was when the stupid bag wouldn't stay on. He said he was ashamed. And now it was my turn to be shocked. And I really do think that women are better at these things. There's nothing to be ashamed of. His body was letting him down. And after that, he accepted it and never really complained. He was an upbeat kind of guy, and always appreciated what the doctors and what the nurses were doing for him, and he let them know it. After the surgeons, there's the oncologist who hands him on to the radiologist, 4 weeks of treatment, and then they add a little chemo at the end of the radiation treatment, and that, it seems to me, is what really did him in. This is an unprofessional opinion. He can't eat, he's dehydrated and really in terrible shape. And 1 week after the end of radiation, he has chest pains in the middle of the night, and he never had any heart problems up to then during the illness. So ambulance, emergency room, and finally a bed in cardiology the next day. On Friday, Roger's sister is there. We spend the entire day in the hospital. He can't eat, he can hardly finish a sentence, and then we're told he's to be discharged the next day. No doctor to be seen. They bring him food for a heart-healthy diet when the man has been vomiting for a week and cannot keep down a sip of water. I had the sense that in the cardiology wing, nobody knew or realized how ill he was. At 6, I asked the nurse to speak to a doctor, and she finally calls me. There's someone around, a resident, who is not actually there to see Roger, but he happens to be there, and he repeats to me the bit about discharging him, and I'm in complete disbelief. And I still wonder to this day whether at that point I shouldn't have made a huge fuss. Would it have made any difference? I don't know. But I did learn later that in some pediatric wards, there's a phone number that any member of the family can pick up when they know that the child is not doing well. Who, after all, knows better than the family? Had it been there, I would have picked it up, and so I blame myself. We finally leave at 7:30, and at 12:20 a.m., call from the hospital, cardiac arrest. They've been working on him since 11 p.m. March 6, 10 minutes after we arrive, he's gone. Truth be told, Roger may have been spared the worst. But something struck me all along. If you watch the shows on TV, whether it's House or ER, there's one huge fantasy element that doesn't jive with the way medicine is practiced today. On the TV, it's the same team that does diagnostics, tests, pathology, and even surgery. But we all know that's not the way medicine is practiced today. When Roger was admitted to cardiology, I felt that cardiology only looked at one thing. And in fact, at each stage, the patient was divided into pieces and passed on from one specialty to another. I saw his oncologist in the hall the night Roger died. He did not know me. I do know for a fact that radiology did not know of Roger's death until more than 3 weeks later. After, that is, I had complained, and I think the hospital must have contacted them, and then they realized what had happened. And this puzzles me, because wouldn't they be interested in the outcome of their treatment, especially since this was an unusual and highly aggressive form of cancer? Might his case have been of interest for future patients and future treatments? There was much reassuring talk all along about teamwork, but in some ways, as Dr. Becker has pointed out, it more resembled a relay race, handing the patient from one specialist to another. That's why I called the patient representative after Roger's death, in the hope that there would be greater coordination and integration of the patient as a whole human being. I know that's not the way medical training, with its specialization and its incredible demands, is carried out these days. But that's what I'm here today to advocate. few days ago, I had an appointment at the hospital for nothing serious. It was terribly hard being there. It has become for me a lieu de mémoire, a map from the land of illness. Each day I tick off the anniversaries from the preceding years. And we're coming around now to the second anniversary of Roger's death. In the meantime, Roger's books have been donated to a library of American Studies in Paris. His artworks are at the University of Virginia Art Museum. His ties were sold to benefit their synagogue preschool, and his Harvard robe donated to Harvard for an impoverished Ph.D. I hope I've given you some idea of who he was, of the whole person, and that in your practices, you'll not forget to see beyond the symptoms and the illnesses to the human beings being entrusted to your care. Thank you for this opportunity.
Thank you both for a wonderful talk. We have plenty of time for discussion, for your comments, your participation in this forum. We've been given a lot of information to think about, to put together. And I'll bring the mic to those of you who have questions and comments. There's a lot to absorb. Please identify yourself.
Stewart. I think one of the challenges on your rather large circular grid of things that confound us, I guess I would say, how do you get past that sort of bias that you bring to what you're seeing in front of you? You mentioned cardiology, but I don't think it's limited to an area. How would you suggest that we get past that bias, that we have a set of symptoms, we have a patient's history, we have what the family tells us at that moment? Can you help us think about how we would broaden our view?
I guess that's my question. That's one of the $64,000 questions. So I'm a generalist. I see the big picture, and I can still go off on tangents. I think, there's a book by Jerome Groupman, How Doctors Think. I think no matter what we do, there are going to be cognitive errors. I think teamwork helps. I think sort of constant feedback. Are we going in the right direction? I'm not sure that, I think in Roger's case, it was much more than cognitive error. I think it was really, as Jenny described, failure to appreciate how sick he was, and to really, I left out a couple slides on empathy, about trying to imagine what the patient's going through, and what it would be like to send people home.
Is it a failure to recognize how sick, or did we expect him to be that sick because of his condition? Did we already expect him to be that sick?
I'd be second guessing. I went through the chart, and I think there is real pressure to discharge by noon, and his acute cardiac problems seem to have been resolved. I actually went up to see him Friday afternoon. One of the things about Roger is he smiled all the time, and you go to the bedside, and he was happy to see me, and I was sort of deluded by that. I thought we had sort of avoided another disaster, and that it wasn't even worse. I think something that we need to really internalize is the idea of team-based practice in a way that really matters, so that whatever the problem, Roger happened to have a particularly terrible cancer, and a very painful cancer, and often I think clinicians in the audience and people who've done palliative care appreciate that when somebody dies from a terrible disease, that part of you sort of celebrates the relief from suffering, because we can forecast what's going to happen. Poor Meg Barkley, whose probably ears have burned off by now, but I think we need people like that. And I know we do have people like, I bump into people like, I can't turn around without bumping into people like that, but it doesn't always work out. I also want to mention that the medicine service does now have a system just like on pediatrics, where if Roger were in the hospital now and Ginny didn't like what she saw, she could get help immediately and people would arrive.
Hi, I'm Steve DeCosti, I'm the Dean of the Medical School. Dan, if let's say that there was no crush for beds, if he had stayed in the hospital, had not been given an order for discharge, what happens? What did we learn about that if we got to backtrack it again, like in a movie, and got a different view, like view number 8 from Rashomon? How would we have done things differently? What's our lesson here for backtracking or being more vigilant because there was something we might have seen before?
Well, I do primary care, but I also cover palliative care on the weekends, and there are a lot of palliative care consults just for people like Roger, where the people can forecast what's going to happen, and we need to develop a plan of care that takes all that into account. The fact that he wasn't eating or drinking, that he needed more time, maybe he needed to go down to palliative care service on 3s. But I agree with Sir William Ostler that we've all missed thoracic aneurysm and things like that. We are never going to be 100%. People who go into medicine and nursing, a lot of us are perfectionists, and our training doesn't cure us of that. We think that we just hope that next time we'll get it right.
You didn't miss the aneurysm. It was in the history.
Yeah.
Was it reasonable to expect that you should have seen the incipient rupture? When I think about things to learn from it, the palliative care piece, okay, clear. Should you be holding yourself responsible for, or should someone be responsible for incipient change that Ostler wrote 100 years about, and that we don't have much more in the way, and especially if it's not symptomatic, ways to detect it?
I'm going to ask
Just
Ginny,
in the context of what we learn for the future.
Well, I think that if Roger had been sitting there and we'd had a family meeting and we had recognized that he needed more time to encourage sort of the oral intake and have a care plan with continuum or hospice coming out, and then he had sudden chest pain and hypertension, would that have felt different, Ginny?
Does this work? Yeah, I think so. I just remember being this sense of complete disbelief that someone who was obviously that ill could be sent home in that shape. And apparently, the heart, whatever was suspected was okay, but this was obviously someone who was extraordinarily ill. And perhaps if you did not know him, because there was a sudden, I thought, very, very sudden change. And I was aware of it because I've been through all the radiation and the chemo and all of this. And it was real, and he was doing really quite well until a few days before. whatever it was bad. And I did not feel that the seriousness and the degree of change was somehow registered. And again, I do think it was because the cardiologists were looking at the heart and nothing else. And there one wonders, I'm sure that all of us wonder about the role of the family or the close friends who have been with the patient over a period of time. And I do think that their judgment is something that should be taken into account. We're not hysterics. Most people aren't. In fact, most of us, there's something about being in a hospital that actually makes you feel confidence that care is being given. So that when there is such a change, that I think it needs to be regarded. And as I say, my sense was that the extent and the multiple facets of his illness were not really registered.
Bob Chevalier in Pediatrics. This week's New England Journal has an editorial on the emphasis on patient involvement in their care over the last few decades in America. And that's something we've been touching about in the last 45 minutes. But I'm wondering, with respect to the last few months of Roger's illness, I don't think we heard too much about his involvement in these decisions. You made a reference that he chose not to be involved, I think. And do you want to make any comments about that?
I think that the way the illness unraveled, it was, we just weren't clear, but I was kind of pushing for some kind of surgical solution in order to help him avoid a lot of pain and suffering. Just the location of this cancer, I was hoping not to cure him, but to I thought the best hope for palliation would be surgical. And there was a lot of back and forth, you know, he'd be well and then he'd get, you know, he had a nephrostomy tube, he'd get infected, his fever would go up, he'd have sort of present in sepsis, he'd need a couple days in the hospital, so that there was very little time to kind of stop, take a deep breath, sort of, we were always moving to sort of the next step, or restabilizing him and then trying to get him healthy enough to have this procedure.
I'm Caroline Engelhardt. I teach health policy here. I want to thank you both very much for this really instructive and moving story. But each of you alluded in your own ways to the problems surrounding discontinuity of care. And it reminds me, it makes me wonder what is going to happen. I have residents that rotate with me some, and I do know that with duty hours for residents being reduced, there are more handoffs. And if we know that more errors happen during handoff, I wonder what we can do as an institution to anticipate that and compensate for that. And I don't know, Danny, if you know that or can speak to that, but to Professor Clay, I wondered from the patient's perspective, from the patient's family perspective, what would you have liked to have seen that would have made you feel there was less discontinuity in his care?
Well, I think there were several things. For instance, when Roger was admitted with the heart problem at night before, I had no idea who was seeing him. And he did have a heart person, a cardiologist. I don't think he'd seen him in 2 or 3 years because he had had problems. So I have no idea who saw him. I think every time, I do think the ER is a problem in terms of continuity. Because, for instance, Roger, I don't know how many times, he had the F tube infection, which is apparently very common. And I could diagnose it, I knew what was wrong. But where do you go after 5 o'clock? There's no place to go but the ER. Once you get to the ER, you are there, depending, if you're lucky, you can get out of there, and there's a bed. But there's no place to go besides the ER. And each time, somebody new sees you. I think that divides up the person. Now, I understand everything is on the computer. The whole history is on the computer. But each time it's a different. So that's one of the things that divides you up. Now, the other thing is, I don't think the oncologist talked to the radiologist. And I don't think the radiologist talked, I think that there is a handing over. And that I think the really essential thing is to have somebody who's looking at the whole picture. And who can tell, for instance, that he was doing fairly well with radiology until they added, and I don't know what it was, a little bit of chemo. And all of a sudden, now, that somehow never got registered. And I really think that was the precipitating factor. I'm not a doctor. But somehow there was a precipitous change at that point. And again, I wonder if it hadn't all been followed through more carefully and coordinated more carefully. So ER, the fact that you always see who's ever there, and the coordination in the different steps in the treatment. I think after he saw the surgeon, after the 6-week checkup, if you like, I don't think he ever talked to the surgeons again. And he liked both the surgeons, but that's the way it's done. And I don't know what the solution is.
Gordon Putnam, chaplain at the Cancer Center. It sounds like he was diagnosed in November with a life-limiting condition. This cancer was going to cause his death. Was there ever a time from that point on that there was conversation around what do we want to do, how much do we want to do, when do we want to stop, how does he complete his life, how does he want to live the rest of his life? Was there any of those conversations with any of the doctors or any of the staff or somebody to help say, wait a minute, what do I need to do to be ready to die? Because that sounds like really what happened was you guys weren't ready for him to die.
We were ready, but not that way. Not boom. Yes. And those conversations we did have. He had medical directives. He talked to palliative care people. And I think that we did feel that when he went into for the surgery, that would buy some time and some comfort, physical comfort. But we knew pretty well. I don't think there was any sort of fantasy about cure. That was pretty clear right from the beginning. How fast it would go, I think I mentioned Roger thought it would be a year, 2 years. That was not the case. And then after the surgery, it was pretty clear that there was nothing at all to be done, and it was very aggressive.
I had sort of a running conversation with Roger about what was going on. I remember going to radiation therapy and being there with him and sort of deciding what to do. So we were prepared for him to die of urothelial cancer, not to die suddenly on the acute cardiology service. And I think that Roger was, I don't think that he was having an unusual problem with sort of existential suffering. I think he was just hoping to get married, take one more trip.
My name is Karen Knight, and I'm in the Health Sciences Library. I feel like I'm channeling Steve Horowitz. I don't know if he's in the room, but I always learned from him about the importance of not just charting the facts of a patient's case, but telling a story. And I just wonder if that would have, and now that we're in an EPIC system where it's so easy to chart facts and not write out a patient's story, if either one of you wants to comment on, would that have helped? Because maybe that would get at the idea of severity in a narrative fashion and just how important those narrative skills are in patient charting.
I just want to defend EPIC for a second because there's this thing called the in-basket, and these days I will get a result in my in-basket, and for example, I can call a patient and say, hey, your biopsy was negative, you don't have cancer, and I can do that a lot more quickly than I ever could. Or I know when someone's in the emergency room and suddenly, that we're in a completely different ballgame, and I can call the patient almost as soon as they get home. But I think what we're losing is sort of the patient story and the story that Jenny was so eloquent in sharing with us. We have to work hard to preserve that somewhere. I mean, it's still possible to do that in EPIC.
I'd just like to make a bit of a turn in some of the questions and just ask you, a case with a situation with an outcome like this often leaves some or all of the health professionals who are involved hurting for themselves as a result of something going as badly as this ended up doing. Do you know of anything that was done or offered in any way for some of the people who had taken care of Roger, or were they all sort of dealing with this on their own?
I know that's part of what when a situation is brought to the patient representative, then the involved doctors have an opportunity to respond and think about it, and a lot of the time that prompts them to go to whoever they need to go to sort of share a bad experience. I think that's done more informally at a personal level than an organizational level, although there are moral distress consult services now. And I think that whenever something terrible happens and you blame yourself, then you need to talk about it. You need to share it. You also need to acknowledge, what if you can. Part of my message is that it's so complicated. Placing blame isn't so easy.
It may not really be the answer.
Yeah. Of course, we can always blame the hospital, and that's what we do. But to say, I'm just kidding. But to say that it was an attending or a nurse or a resident who dropped the ball, I think it was more of a systematic failure to get the story right.
I'm afraid we're at the end of our hour, but I would invite you, first of all, to come back next week. It turns out it may be more of a segue to next week's program than I'd realized. We have psychiatrist and medical anthropologist Arthur Kleinman here with us next week from Harvard. He'll be talking about caregiving, revitalizing its place in medicine. And so join us for that. Meanwhile, please thank Danny Becker and Jenny Clay and the Richardson